Assalamu alaikum wa rahmatullah. Today I'll be talking about management of red eye in primary care. This is Lucian Aziz Rahman. I'm an ophthalmology resident, and I've prepared this presentation for family physicians and primary care providers to help them in navigating red eye. So the topic of red eye is very large and it has a lot of differential diagnoses. But our goal in this lecture or in this video is to try to understand what are the common causes of red eye and what are the management options in primary care, and most importantly is when to refer to ophthalmologist, because some conditions can be greatly affected if it's left for a long time or if it's managed in an inappropriate way. So the differential diagnosis of red eye include the conjunctivitis, which is the most common cause in primary care, blepharitis, corneal abrasion and chemical burns, foreign bodies, subconjunctival hemorrhage, keratitis, iritis, and scleritis. So when a patient comes to you with red eye, you take general history as we take in medicine. You should ask about the age because the differential would be affected by that, especially if we're talking about a middle-aged patient with recurrent redness, for example. We'd go more with an autoimmune disease or episcleritis. The other things that we should take is the medical history, including any allergic condition, asthma, eczema, allergic rhinitis, allergy to food or medication, any autoimmune disease, any other systemic disease, including hypertension and diabetes, and so on. Then we should take any surgical history, any recent surgeries, whether ophthalmic or systemic. And finally, we'll take more history on the ocular history. So in the ocular history, which we should focus on the main complaint, which is the red eye, and other associated symptoms. So for the red eye itself, we should ask, is it unilateral or bilateral? If it's bilateral, was it sequential? It started in one eye and then it developed in the other eye, for example. What's the chronological history of the redness? When did it start? For how long? Is it recurrent? Did it come before? Did it change over time? Like, did it worsen or improved or anything like that? Also, we should ask about trauma, recent surgeries. Contact lens use is very important to us. And when asking about, it's not enough to ask whether the patient is or using contact lens only. We should take further history. For example, what is the type of the lens? Is it monthly? Is it daily? What's the hygiene habit of the person? Does he wash it with like tap water or with the solution that comes with it? Some patient, they use the same contact lens over and over, although it's, for example, single use only, or if it's monthly use, sometimes they use it for years. Other thing that's important is the patient sleep with the contact lens, or does the patient shower with it? These are all important and are alarming if they are positive. Any visual changes? Is there any blurriness of the vision, decrease in vision? And when asking about visual changes, we should focus on, is it true visual change or is it true visual loss, or it's only like mild blurriness of vision? We usually ask about this by making sure, does the patient have blurriness of vision all the time, or it comes and goes? Does it improve with blinking? All these things point us to benign condition rather than true visual loss. Pain, and when we ask about pain, we should ask about severity. Is it like really severe on a scale of 1 to 10? And one of the indications for severity is about asking about, does the pain wake you up from sleep or prevent you from sleep? All these things are indication of really severe eye pain. Other thing is photophobia, and photophobia is like being unable to look at light directly, whether the room light or the sunlight. Um, Other thing is discharge. When there is discharge, we should ask about the color. Is it yellowish, greenish? Is it like whitish? What type is it? Is it mucoid? Is it like pus-like? And amount, is it cubaceous? Is it a lot, or it's only small, minimal amount, only when waking up from sleep? The final thing is itchiness. Is there any itchiness associated with the red eye? So for ocular exam, our vitals in ophthalmology are the visual acuity and the intraocular pressure, or the IOP. These two indicators of how severe is the disease and how it's affecting the function of the eye. Other examination include pupillary examination and pupil reaction to light. Also, external examination of the eye and the eyelids, and examination of the conjunctiva. The most importantly, if we see the redness or hyperemia, we should look at the location and the pattern of the hyperemia. Is it diffuse and all over the conjunctiva, or it's only in specific or sectoral area? All of these are indicators of the disease. Also, we should examine the cornea if there is any like an abrasion, an infiltrate, any whitish opacities, any foreign bodies. And finally, we should conclude by lymph node examination, which is very common to have with viral disease. So, as I mentioned, it's important in primary care to know your limit, to know when to refer to ophthalmologist. So, one of the important indications are infants at 1 month of age or less, because in this case we're suspecting ophthalmia neonatum, which is a condition that can happen to babies or infants at the first month of age. There are different causes depending on when did the patient present. For example, if the infant present within the first few days of birth, it can be to chemical irritation from the silver nitrate or some topical antibiotics or ointment that they put in the eye, usually to prevent, as a prophylaxis, to prevent any bacterial conjunctivitis. But some babies, they develop reaction to this. For if the patient present within the first week, it can be gonococcal infection that the patient got from the cervix or through the birth canal while the mother is giving birth. If within the first to second week, it can be herpetic or herpes simplex virus. And also this should be managed by ophthalmologist. So this is for the first point. The second point is reduced vision, and as I mentioned before, we should really make sure about the reduction in vision. Is it true, or it's only mild blurriness that come on and off? And also we should make sure that the patient is using his best corrected visual acuity. It means if the patient is using glasses, we should measure the visual acuity with his or her glasses. Because if they are complaining of decrease in vision and they did not bring their glasses, we cannot really rely on that reading. Severe pain. If the pain is very severe, waking the patient up from sleep or preventing from sleep, it's not relieved with topical anesthetic, all these things are alarming. Photophobia. Photophobia, if it's associated with trauma, it is like justifiable. However, if there is any photophobia without any trauma, without any clear cause, then this might be alarming for inflammation or uveitis, and hence need further investigation and further examination by ophthalmologists. Contact lens wearers, because they're at high risk of developing microbial infections or microbial keratitis. Severe trauma or chemical injury. So in severe trauma, because you want to rule out any open globe. Also, severe blunt traumas, they can have effect on the retina. So a referral to ophthalmologist should be done so we can examine the posterior pole in the retina to rule out any breaks, retinal detachment, any commotion retina, and all these things that can happen with severe blunt trauma. Chemical injury, because it will need further follow-up and management, and they're at high risk of having limbal stem cell deficiency, so it should be managed by ophthalmologist. However, if the patient came to primary care, as a primary care provider, you should provide the first aid for the chemical injury, which is irrigation. This is the first line in chemical injury, so you can manage that and then refer for further management. Because the longer the chemical injury stays in contact with the eye, the more severe is the injury. The next thing is headache with nausea, vomiting. Sometimes it can be associated with only non-severe ocular disease. However, if it's persistent, not improving, it should be referred to ophthalmologist to rule out, as I mentioned, inflammation and sometimes any posterior pole involvement or optic nerve involvement. Cubaceous brilliant discharge. In these cases, we suspect severe diseases, for example, gonococcal infection. These bacteria are very virulent and can penetrate intact corneal epithelium. That's why we should manage it in a very timely manner, and we should refer to ophthalmologist. Any recent ocular surgery? Obviously, this is alarming for us. If the patient had recent surgery, then developed red eye or pain, we should refer to ophthalmologist to check for any infection at the surgery site, any inflammation, or any complications. Distorted pupil. Any distortion in the pupil, it can mean multiple things. For example, if it's with trauma, it can mean that there is an open globe and the iris is protruding from that side. Also, it could mean recurrent infection or uveitis, recurrent inflammation, and this caused synechia, or like attachment of the iris to the lens or to the cornea, and hence giving this distorted pupil. Recurrent symptoms: if the red eye is persistent, not improving, it's coming on and off multiple times, it comes sometimes in the right eye, sometimes in the left eye, all these are alarming and should not be managed in primary care. It should be investigated by ophthalmologist. So this is like a roadmap for primary care physicians, when to manage and what to manage and when to refer. This is taken from the great article by the American Academy of Family Physician. You can take a look at it later on about approach to red eye. So the most important sign or the things you want to roll out or you want to ask about is pain. Because in cases if you had severe pain, then you should not treat that. You should refer to ophthalmologist. If the pain is mild or mild to moderate with good vision, the patient looks stable, then you can have further look or you can manage at primary care. So if there is mild pain, good vision, there is hyperemia, you should see if this hyperemia or redness, is it localized or focal, sectoral at a specific area, or it's diffuse. If it's only at sectoral or focal area, then you would think about episcleritis. Although episcleritis can come with pain, but usually the pain is not very severe, does not wake patient from sleep. It's more of a tenderness when pressing at that same area. If the hyperemia is diffuse, we should further ask about discharge. If there is diffuse hyperemia, no pain, and no discharge, then you would think about subconjunctival hemorrhage, and you should ask more about the systemic disease like hypertension, blood disorder, any use of anticoagulant, or these things. If there is discharge, then you should ask about is the discharge, as I mentioned before, the amount, the timing, the color. If it's like more of a watery discharge, come on and off, only when waking up from sleep or when coming to the sun or exposure to windy or wind, then you would think about dry eyes. If there is continuous discharge, then you would ask about the consistency or what type of discharge is it? Is it watery? If it's watery and coming with etchiness, on and off, then or if there is no itchiness at all, then you would think more of a viral. The viral conjunctivitis usually come with watery discharge, mild to none itchiness. If there is watery discharge and there is severe or moderate itchiness, which is the hallmark of allergic conjunctivitis. So itchiness is really important for us to diagnose allergic conjunctivitis. If the discharge is mucopurulent or purulent, then you would think about bacterial conjunctivitis, including chlamydia, gonococcal, staphylococcus aureus. All are common causes of bacterial conjunctivitis. These the left side are the diseases that can be managed in primary care. However, the right-sided are the alarming signs and symptoms that, as I mentioned in the previous slide, we should refer to ophthalmologists, like severe vision loss, distorted pupil, corneal involvement. All these can warn us about severe diseases. So, as I mentioned before, conjunctivitis is the most common cause of red eye. Conjunctivitis can have different classifications. We can classify it based on the etiology. It can be infectious or non-infectious. In the infectious, we have viral and bacterial, and we will talk more about it. In the non-infectious, we have the allergic, which is also common. And then we have those three types, which are not common or not usually seen in primary care. We have the lignous. So lignous means woody in Latin. So you would have like firm yellowish pseudomembranes and the conjunctiva, and it's secondary to plasminogen deficiency. The other one is Stevens-Johnson syndrome or toxic epidermal necrolysis, which is hypersensitivity reaction to antigens. These antigens can be secondary to infection or non-infection. Infection like Mycoplasma pneumonia and Hibris simplex virus, and non-infection including drugs like non-steroidal inflammatory drug, anticonvulsant, allopurinol, and other agents. And the final one is the mucous membrane pemphigoid. This is also this is an autoimmune disease which can affect the mucous membranes of the body. So not only the eye, it can affect the mouth and other organs or other mucous membranes. And usually it's managed by ophthalmologist, and dermatologist. Other classification of conjunctivitis is based on the reaction or clinical examination that we see. We can see papillary reaction or follicular in the lower lid. Usually the papillary reaction we see it more in the upper lid, while the follicular we see it in the lower lid. The papillary, you should see a flat nodule with cobblestone appearance. It seems reddish or hyperemic bit in appearance, while follicular, it's dome-shaped nodules. It's like translucent or like whitish. So talking more about types based on the etiology, starting with viral conjunctivitis. So from its name, viral conjunctivitis is caused by viruses, most commonly adenovirus or which is highly contagious, or herpes simplex or other viruses. It spreads like direct spread by touching the eyes or secretion and then touching the surrounding environment. It's usually associated with upper respiratory tract infection. Usually the patient comes with watery discharge and can have palpable lymph nodes. It's mild, usually mild, with spontaneous resolution, usually within 1 to 2 weeks. So there are 3 types of syndromes that can come with viral conjunctivitis. The first one, the acute follicular conjunctivitis, which is the milder form, can have some sore throat or cold with it. Usually it's very mild and need only supportive care. The second one is the pharyngoconjunctival fever. It is combined of the first syndrome, follicular conjunctivitis. However, it's associated with severe systemic manifestation, like severe more fever and pharyngitis and sore throat and pain. Finally, the epidemic keratoconjunctivitis. This is the most severe form of the disease. It has a severe follicular conjunctivitis and can have petechiae, hemorrhages in the conjunctiva. It can also affect the cornea by having punctate epithelial keratopathy. It might find developed subepithelial infiltrate or membranes or pseudomembranes, and in these stages it should be managed by ophthalmologist, and we usually can give steroid drops in these cases to prevent the membranes from returning back after we remove them, and so the patient does not symptoms become worse. However, we do not recommend starting steroid from the beginning for any case of viral conjunctivitis because it can delay or prolong the virus shedding and hence prolong the presence of the virus in the body or the conjunctiva. So management overall is supportive: cold compressors, artificial tears, and counseling the patient about hygiene, especially hand hygiene and not sharing personal items. There is no role of topical antibiotics because it's uncommon to have superinfection of bacteria over viral. So we should not give antibiotic in every case or in any case of viral conjunctivitis. It's not indicated. Refer to ophthalmologist if symptom does not improve, or if there is corneal involvement, a blurriness of vision, and membranes, as I mentioned. The second type or second cause of conjunctivitis is bacterial conjunctivitis. It's very contagious. You can see from the picture, you can have very severe discharge and redness. The eyes become sticky, and sometimes the patient, they complain that when they wake up from sleep, they cannot open their eyes due to the severity of the discharge. Usually the symptoms is redness, burning sensation, burning discharge, and sticky eyes. Involvement is usually bilateral. However, sometimes they can come with unilateral disease or coming with unilateral or one eye and then develop in the other eye. It is divided based on the acuity or the duration of symptoms into hyperacute, acute, and chronic. Overall, the management is topical antibiotic, and the most frequent options we use in ophthalmology is ofloxacin, erythromycin, tobramycin, and moxifloxacin, or fusidic acid. So based on the acuity of the symptoms, it can be hyperacute with sudden onset, progress rapidly, and in these cases we suspect Neisseria infection, Neisseria gonorrhea in sexually active adults, or Neisseria meningitis, especially in children. They have virulent discharge, a lot of discharge, and they can have decrease in vision. We should be urgently referred to ophthalmology for further management, which we usually use systemic antibiotics. And if it's truly Neisseria gonorrhea, then we should also treat the partner. Acute, if it's less than 4 weeks, this is the most common form to have in primary care settings. In adult, the most common organism is Staph aureus, Staphylococcus aureus, while in children we have Streptococcus pneumoniae and Haemophilus influenza. And in children, they can have associated symptoms, for example, like otitis media, and hence they need further management other than the drops. Sometimes they can use systemic. Topical, the management is topical antibiotic, as we mentioned in the previous slide. For chronic bacterial conjunctivitis, if it's more than 4 weeks, it should be referred to ophthalmologists to look for the underlying cause. One of the common causes of chronic bacterial conjunctivitis is chlamydial conjunctivitis, which is also a sexually transmitted disease. It presents with chronic follicular conjunctivitis, and it's managed by systemic antibiotic and topical antibiotic, in addition to treatment of the partner. The third type is the allergic conjunctivitis. It's usually associated with atopic diseases like allergic rhinitis, eczema, asthma. The patient usually comes complaining of acute bilateral redness, itchiness, which is the most important sign, can come also with tearing and chemosis, sneezing, and nasal discharge. The management is supportive in the beginning, for example, to avoid the allergen, to avoid the usual type of allergen that can cause these symptoms, cold compressors, artificial tears. Other options can include drops like mast cell stabilizers, antihistamines, or H1 receptor antagonist. So the allergic conjunctivitis can have different types or different diseases. We classify them into seasonal allergic conjunctivitis and perennial allergic conjunctivitis, in addition to vernal keratoconjunctivitis and atopic keratoconjunctivitis. So the first two types, the seasonal allergic conjunctivitis and perennial, are very similar to each other and are differentiated only by timing and the eliciting allergens. So seasonal, from its name, it comes in specific seasons, usually the spring and summer, and it's usually elicited by tree and grass allergen, which are common in the spring. Perennial, from its name, it's throughout the year. So, however, it can worsen in autumn season, and the allergen are dust, mites, and fungal allergen. The third and fourth type are vernal keratoconjunctivitis and atopic keratoconjunctivitis. And from its name, it has kerato and conjunctivitis. So kerato, it's the cornea, and conjunctivitis is the conch. So it can have some effect on the cornea. That's why it is a severe form. It's considered as a severe form. Usually it is associated with immunoglobulin E and cell-mediated immunity. It affects boys, usually at childhood till teenage years from 5 to like 18. Usually by advancing in age, the severity of the symptoms decrease. It's seasonal and worsen over the spring and summer. The other one is the atopic keratoconjunctivitis. It is a more severe form of vernal keratoconjunctivitis. Usually comes in adulthood, around 30 to 50 years. It's around the year, but worse in winter. And around 5% of children who have VKC or vernal keratoconjunctivitis can develop in adulthood AKC or atopic keratoconjunctivitis. So moving on to other diagnoses, dry eyes are also one of the commonest presentations in primary care. Usually the patient comes complaining of redness, foreign body sensation, mild blurriness of vision that improves with blinking. It can happen due to decreased tear production or poor tear quality, and sometimes they can have reflex tearing. So some patient, they tell you I'm tearing a lot, and when you examine the cornea, you found these punctate epithelial erosion. And when you tell them that you have dry eyes, they will tell you however, I'm having excessive tearing. Why you're telling me I have dry eye? However, it's called reflex tearing, and these tears are having poor quality. That's why they are not doing their job. They're not doing a great job of protecting the cornea or lubricating the cornea. That's why they have this dry eye. A risk factor including age, female, use of anticholinergic medication with decreased tearing, Sjögren's syndrome, other autoimmune disease. Management usually supportive, like artificial tears, application of lubricant ointment, use of humidifiers if there is any systemic disease to control the risk factors. Blepharitis is also a common condition. It's a chronic inflammation of the eyelid margin. It can be anterior or posterior blepharitis. The patient come with redness, foreign body sensation, and tearing sometimes. Causes can be infectious or non-infectious. Infectious, the most common is Staphylococcus aureus, and other causes include Demodex mite. Non-infectious causes can be associated with seborrheic dermatitis, so you should examine the scalp and facial skin for flaking. And also it can come with acne rosacea, which can have facial flushing, redness, and swelling of the nose and cheeks. Management, usually it's with lid hygiene, lid massage, warm compressors. If severe cases, we usually give topical antibiotic ointment. And sometimes in very severe cases that is refractory to all topical management, we can give oral medication, including oral doxycycline. So these pictures are examples of this is the anterior blepharitis with flaking over the lashes, and this is the posterior blepharitis with meibomian gland dysfunction. You can see these are the orifices of the meibomian glands and they are clogged. So next on is the corneal abrasion. Most commonly it comes in pediatric age, usually trauma with hand or fingernail. It's based on the clinical examination, and our diagnosis is based on clinical presentation and history of trauma and eye examination. Patient come with pain, photophobia, tearing, blurry vision, redness. It can be caused secondary to trauma, exposure, keratopathy if the patient has, for example, seventh cranial nerve palsy, or if the patient does not fully close his eyes through sleep, then it can have corneal abrasion. Also, it can be due to herpes simplex virus. So usually in examination, when you put the fluorescent dye and then you apply the cobalt blue filter, you would see different type of staining of the cornea. The important red flags or things you should see is the branching pattern. If you see this branching pattern, then you should suspect herpetic infection. And also if you see this vertical pattern of staining, then you should suspect a foreign body and you should avert the upper eyelid and look for it, because this is very typical, having these vertical abrasions. They're coming like this because when the patient closes and opens the eyelid, then the foreign body which is present in the inner part of the upper lid, it fricks, or the friction of the foreign body with the cornea, up and down, it's what causes this vertical abrasions. Management, we usually manage pain by cycloplegic agent like cyclopentolate. We give topical antibiotic like ofloxacin, moxifloxacin, torprofloxacin. Usually it will the pain and the abrasion will improve over time, especially like within 1 week. If no improvement or worsen within the first 48 hours, it should be referred to ophthalmologist. And for sure, if it's herpetic infection, it should be referred for ophthalmologist. Other benign condition includes subconjunctival hemorrhage. It's diagnosed clinically. Usually the patient have normal vision and no pain. They complain that they've suddenly woken up from sleep and they saw this red patch on their eye. You will see sharply demarcated area of blood under the conjunctiva. You should rule out any trauma and corneal involvement or penetrating injury. You should also check blood pressure because it's one of the commonest causes of subconjunctival hemorrhage. So when we say about causes, it can be due to eye rubbing, heavy lifting, coughing, high blood pressure, bleeding disorder, and use of anticoagulant. Management, it's reassurance. It will go by itself within 1 to 2 weeks. However, if it's recurrent and the patient is not known to have systemic disease, then you should investigate for systemic disease, including hypertension and bleeding disorders. Finally, we would talk about episcleritis. From its name, epi, it's above, scleritis, the sclera. So it's a localized inflammation involving superficial layers of the sclera, of episclera. It's a clinical diagnosis. Usually the patient comes with sectoral redness, pain, tenderness at that area. The causes can be idiopathic or secondary to other diseases, including autoimmune diseases and rheumatoid arthritis. Management, it's self-limiting. And usually we use artificial tears, non-steroidal anti-inflammatory drugs as oral medication to improve the symptoms and reduce the inflammation. Ophthalmology referral is required if there is multiple or recurrent episode, or if the patient does not improve, or if the pain is very severe and preventing the patient from sleep, because in that case we would think about severe involvement and of the deep layers, which in that case is called scleritis, not episcleritis. Investigation of the underlying cause, it's only if there is recurrent symptoms. So thank you for your time and listening. This is all about my presentation. My references were the American Academy of Family Physician, the article Diagnosis and Management of Red Eye in Primary Care. I truly urge you to look at that article. It had other details that you can look at it. Other references I use, the American Academy of Ophthalmology website, and CASI Clinical Ophthalmology Systemic Approach book. Thank you so much. And feel free to ask me through the comment box or through the comment section.